Well, hello everyone. I want to thank you for joining our webinar today with Dr. Joseph Goldberg on the topic of overcoming obstacles to treatment, adherence, and bipolar disorder. And there will be a 15-minute question and answer session at the end of the talk, so please feel free to type your questions in the chat box at any time throughout the discussion. And our guest today, Dr. Goldberg, is a clinical professor of psychiatry at the Icahn School of Medicine at Mount Sinai and president of the American Society of Clinical Psychopharmacology. And he attended college at the University of Chicago, graduate school in neuroscience at the University of Illinois Chicago, and medical school at Northwestern University Medical School, and completed his psychiatry training and psychopharmacology research fellowship at the Payne Whitney Clinic of New York Presbyterian Hospital. And his research has focused on clinical phenomenology, treatment, and outcome of mood disorders. He has published over 240 peer-reviewed papers on psychopharmacology and mood disorders, as well as 5 books. He serves as deputy editor of the Journal of Clinical Psychiatry and an associate editor for the journal CNS Spectrums. Dr. Goldberg is a distinguished life fellow of the American Psychiatric Association and has been listed for many years in Best Doctors in America and Castle Colony's America's Top Doctors. Thank you for joining us, Dr. Goldberg.
Well, thank you for having me. I appreciate the opportunity to speak with you today about a truly important topic, which is adherence in treatment for bipolar disorder, whether you are someone who experiences the illness yourself, whether you are a caregiver or supporter of someone who has this illness or otherwise involved in its management and treatment. Adherence issues become critically important in understanding really what goes into the whole process of recovery. So I want to make just a few comments at the outset. I have a few slides, I promise only a few slides to try to illustrate some points. But a first point just starting out is we often struggle with what goes into relapse and recovery for people with bipolar disorder. And if one surveys literature, guess what the number one cause of relapse is? It's not inadequate treatments or ineffective treatments or side effects or treatment-resistant symptoms. Those are all things that count for a lot, but non-adherence tends to highly outrank everything else. So if I'm treating somebody with this illness and they're stable, but then they're showing signs of relapse, I always have to remind myself, after decades of doing this, when I think, oh, someone's relapsing, what should I change about their treatment regimen? I have to take a step back and not assume that the treatment regimen is inadequate, at least in terms of what it could accomplish biologically, but rather, have they been taking their medicines time and time again? Because poor adherence is common, because it happens for so many reasons. And because to not think of that as a first piece is just a shortcoming. So sometimes clinicians just change medicines a lot without stopping to think, wait a minute, did we have something that was working, it wasn't being taken? And if so, why was it not being taken? Because before I say, well, let's move on to something else as the next treatment, could happen again. So it's important to understand what goes into ambivalence about treatment adherence or otherwise obstacles to it. Start with a definition. So adherence, or sticking with a plan, experts define as about 80% of what you're supposed to do, you do. So perfect isn't necessarily the objective. It's nice, but when people study treatment adherence, whether that's to medicines or psychotherapies or other aspects of a recovery plan, are you doing about 80% or more of what you should be doing? Do you miss more than 20% of your doses of medication? And because problems with adherence occur in well more than half of people with bipolar disorder, in itself, it could become a kind of a stigmatizing thing if we don't address it delicately. So that means not asking a patient, so are you taking your medicines as prescribed? I mean, that's a bit of a loaded question. How are you supposed to answer that? No, I'm not. What are you going to do about it? As opposed to, let's say, a question that frames it differently, such as, many people have a hard time taking their medicines as prescribed. How often do you find for yourself that that's difficult to do, and almost normalizing the experience for people, very non-judgmental and very practical, very pragmatic. Um, and it's not unique to psychiatry. You take a 14-day course of an antibiotic. How many people really take all 14 days of it? Um, so in some ways, it's useful whether you're the treater, the caregiver, the supporter, or even the patient themselves, to ask, well, what goes into skipping doses, missing doses? And lots of things come up. Forgetting, not liking a medication, not liking a reminder of a medication, side effects, cost, burden of taking medicines. I'm feeling better. Do I still need these medicines? I encourage curiosity when it comes to understanding adherence. So again, not let me catch you in the act. Aha, I found your stash of pills. You haven't been taking them. It doesn't go far at all, but rather we need to understand what's going to help you get well and stay well. And because for so many people, missing doses of medicines or not taking them properly as prescribed, or understanding what goes into that is far and away a critical starting point. I want to just share my screen with you for a second. This is a list from, well, a book I have that just came out very recently on decision making in psychiatry. And I just want to share this summary of reasons that have been identified for poor adherence. So some of these I touched on already, but as you can see, it's a long list. Side effects. I don't know enough about my condition to make an informed decision about whether I have buy-in to taking this medicine, which you tell me I ought to take. Or maybe I don't fully trust the information that I've been given. Or an apprehension that maybe I'm going to have more harm than benefit from this. And that also bears on what my past experiences have been in terms of side effects or less than stellar outcomes. And speaking of side effects, is that an all or none proposition? If I get a side effect, does that mean I'm stuck with it? Or I have to just, power through it? Or are there ways to manage side effects? There are ways to manage side effects. More and more, that's become a focus of attention. How to manage everything from weight gain and movement disorder problems, sexual side effects, sedation, sleep problems. There's a whole area of side effect management that's really coming into its own in psychiatry. Complexity of dosing regimens. I'll say more about that in a second. Cost, I forgot. Hassle. You're taking a medicine that requires blood tests, requires a very high level of engagement and involvement, which people are sometimes more keen to do when they're aware of feeling poorly. But once I'm well, do I really want to go get my blood work done with this frequency? And if I've got other things happening in my life, it becomes almost a competition for my time. And if I am doing well and reaching more of a recovery plateau, maybe I'll even ask something: do I still need this medicine? Can I simplify my medicine regimen? So lots of factors go into this. So I'd like to share with you what I think is a kind of an astounding set of statistics. This was a survey of the Depression and Bipolar Support Alliance published a few years ago by a colleague of mine, looking at reasons why patients stop medicines. And the top two reasons: I didn't think it was working well enough, and side effects. Neck and neck. This tells us that deal breakers for staying on a treatment regimen are not simply side effects and are not simply it ain't working. It's both. And rightfully so, patients themselves want efficacy as well as tolerability. Now, treatments can be imperfect. We know this. Here's another corollary from that study that I just mentioned to you. Complexity of treatments and treatment regimens can make it challenging to have reasonable adherence, that 80% mark that we talked about. So I found this to be astounding information from this patient survey. How many people with bipolar disorder just take one psychiatric medicine? 2.6%. How many only take two? Another 6%. 3 to 5, a quarter. 6 to 9, almost a third. And 10 or more, 34%. And not only that, but most people didn't find them that effective. Less than 30% said, Yep, I'm taking 10 or more medicines and they're really effective. So, what's the surprise with shaky adherence if you're taking a plethora of medicines that most people don't even acknowledge or identify as being all that helpful? So, I think empathy for the plight of the individual who is taking multiple medicines that they may or may not believe is helpful has to factor into our thinking about what goes into um, uh, adherence, right? Um, so, uh, here are some statistical things that, besides what I've just told you, go into the equation of understanding obstacles to adherence. Some of these are demographic things, younger age, being single or not in a relationship, ethnic minorities, poor social support. A word on social support as well. There's been a growing interest in understanding the extent to which people within a nuclear support network, whether it's a family or friends, are aligned in their thinking about recovery from mental illness. So imagine one scenario where well-meaning family members might make critical remarks about someone's mental health and the medicines they're taking and pointing out side effects and skepticism and potentially say things that could be highly undermining, such as, are you still taking that medicine? I don't know why you're taking that medicine. Um, oh my gosh, look at all the side effects that medicine is giving you. Do you know how expensive your medicines are? Or another route, which is more sort of wielding a kind of an approach over medicines, which is, I don't like the way you're acting. Are you taking your medicines? Um, have you taken your medicines today? Which may be a well-meaning inquiry, but could otherwise be perceived as more of an assault on a sense of autonomy and a reminder about symptoms or a statement that questions whether the treatment's even effective. So whether supporters realize it or not, their comments count for an awful lot. And if you find yourself in an environment where there's not an alignment of how one thinks about treatment or symptoms or the pros and cons of medicines or the imperfections of medicines, um, uh, disalignment of social supports or helicoptering or over involvement or negative critical approaches toward treatment can really drive some of the non-adherence that goes on. How do you deal with that? What do you say to a loved one or a caregiver or a family member who makes critical comments? I mean, that's a tough one. It casts the patient in the role of having to say things like, look, I didn't ask for this condition. I mean, bipolar disorder affects 2 to 4% of the population, depending on whom you read. Depression's a big driver. Symptoms often persist even with excellent treatment, and side effects unfortunately occur in 2/3 to 3/4 of patients. Sometimes those are very significant side effects. You come by this honestly, and you're working really hard to try to make this as successful an outcome as possible. I really need your support. And if you have concerns about my medicines or my side effects, let me help you articulate how to bring that to my attention. Because if there's anything that feels negative or critical, it's called expressed emotion in the literature. That is, intentional or not, communication styles that just foster poor adherence or a sense of inadequacy or failure can drive relapse, maybe in part through fostering poor adherence. Lots of other things that go on the list of adherence. I've been talking some about side effects, attitudes, medication attitudes. Do I still need this? But then there's other things that can come into the picture as well. So that's listed in this box over here. Bipolar subtypes, episode and symptom features, comorbidities, and suicidality are all aspects of the illness that figure in. So imagine somebody with psychosis, delusions, hallucinations, something that happens in half or more of people with bipolar 1 disorder, that can often go with loss of insight. And that's not just, I'm fine, I don't need the medicine. It is an honest to goodness lack of awareness of the illness, almost like a neuropsychological, not almost, a neuropsychological phenomenon. I don't see anything wrong. I don't see a need for medication. It sort of challenges or questions one's objective assessment of, am I having a symptom? Yes or no. You have a toothache, you usually know it. Stomach ache, usually know it. I'm having paranoid delusions, maybe not so obvious. You may not say I'm having a flare of agitation or feelings of persecution. I'd better go see if my medicines are being taken properly and are at the right dose. You may not even acknowledge that those are symptoms in the first place, because the nature of the symptoms themselves can interfere with your ability to test what's real and what's not. I like to talk about the notion that the brain can play tricks on us. We don't necessarily reliably trust our senses. Think of optical illusions. Think of if your hand falls asleep and you're not sure if it's your hand. The brain can process things in certain ways that may make us think inaccurately about the need for addressing a symptom, a role for medication, or possibly even making misattributions about what a medicine is doing. Someone recently was talking to me about manic symptoms, and they were taking an anti-manic medicine. Actually, it was lithium in this case. And they were wondering if the lithium could be making them manic. And I said, lithium's not really known to cause mania. It's possible that it's failing to fully help your mania, but they actually read something somewhere that lithium can make you worse or can cause depression. So they stopped their medicine and they were relapsing. And their non-adherence was either based on wrong information or a misperception that the thing they were taking, presumably to make them feel better, was making them feel worse. Comorbidities, additional psychiatric problems, are another big complicator of recovery in bipolar disorder. And as many of you probably know, most people with bipolar disorder don't just have bipolar disorder. 3/4 have a second psychiatric condition. Often that's anxiety disorders like panic disorder or generalized anxiety disorder or a phobia. Often, about half the time, it's a substance use disorder. Alcohol or substance use becomes its own condition, its own diagnosis. Some people frame that in their minds as self-medication, and if only my mood was better, I wouldn't be using substances. And sometimes that's true, but sometimes substances are their own disorder and need their own treatment. And many substances interfere with the metabolism of psychiatric medicines, will render them less effective, or create their own psychiatric symptoms that overpower the effects of psychotropic medicines. Net often being, why am I taking this medicine? I'm not getting better anyway. Someone once said to me, gee, the medicines you give me make it harder to get high. Or if I go on a binge drinking episode, I don't feel as well afterwards. So a lot of education around what are all the elements that we're trying to treat and how do medications interact with that. We have psychological features down here. So I touched on this already to some degree, attitudes and beliefs about medicines. There's often a cultural overlay to this or a sociocultural overlay. Do you believe that medicines are categorically helpful, unhelpful, things to be regarded with a sense of suspicion? I've had some patients who will protest to me and say things like medicines are unnatural. They're created in a laboratory. They haven't been fully tested yet. They're just a tool for the pharmaceutical industry to make money, and I'm being exploited. So a lot actually goes into those kinds of attitudes, but also I think a very fundamental one that I touched on a little bit earlier is, do you anticipate or expect that medicines are going to render relief? Which is to say, will the benefits outweigh the risks? Do the pros outweigh the cons? Now, this is very individually based. Someone who's been through many episodes or incomplete recoveries or remissions after episodes, who sort of lives to tell the tale of, I've been on these, what does that DBSA survey say, 10 medicines with a 29% rate of effectiveness. Why should I take more medicines? Engendering some skepticism. What do I anticipate is going to be the benefit to me if the number of things I've taken before haven't been so helpful? I think this is a really important point because people learn from experience and are not ignorant of what their past experiences were. Imagine if you ate at a restaurant and it was a terrible meal and you got sick after. And then you go to another restaurant and you have another meal and it's terrible and you get food poisoning. Do this enough times and your friend says, you want to go to a new restaurant, you may be skittish about that. Or let's go back to the one you went to before may not fill you with a sense of expectation that this is going to be a positive experience. So now instead of a restaurant, imagine if previous medicine trials that you had taken yielded negative outcomes or outcomes where your perception was more side effects than benefits. So if I see someone in a consultation and we're going over their previous medicines and I say, what do you recall about drug X? It gave me weight gain. Okay. And what do you recall about drug Y? It made me very agitated and irritable. And how about drug Z? Oh, I was a zombie with that drug. I hear this a fair amount in talking with people with mood disorders in general and bipolar disorder in particular. And then when I ask, I'm sorry to hear you had these bad experiences. Can you remember any benefits? People sometimes tend to remember the negatives more than the positives. And admittedly, if there's a long list of side effects, you're going to have to squint to see benefits. But it does raise this question of, was a medicine previously abandoned because the side effects outweighed the benefits, or there were no benefits, or there was a benefit, but there were side effects, and nobody really stepped in to address how to make the treatment more manageable. That is, wow, this treatment is really having the following positive attributes for you, but here are the negatives. So do we just throw it away? Do I turn my head this way and say, I assume you're taking it, or chase after and say, are you still taking that treatment that's giving you all these side effects? Or do I say, look, I understand this medicine, it can be hard to take, but let's talk about whether there's a way to make it more user-friendly. And again, this goes back to side effects being treatable or not. Complexity. Oh, those 31% of people taking 10 or more psychiatric medicines. Complexity is not easy to follow. How do you keep track of all the medicines if you're in that unfortunate group of people taking so many? Now and then, combination medicines are clever and capitalize on favorable drug interactions. Let's call that synergy, so that I put this together with this, and I make something that's quite beneficial, whether that's by virtue of the mechanism of action of the drug or targeted symptoms. I take lithium because it helps reduce suicide risk. I take lamotrigine because it's got value to prevent depression. I take lurasidone because it pairs well with lamotrigine. It's not redundant. It treats depression. And it may have some pro-cognitive effects. I take gabapentin because it helps with anxiety and sleep. I like to tell patients to think of medicines like personnel rosters, and you're the head of HR. So from time to time, let's go through the roster and drug by drug, do a performance evaluation, identifying the niche to be filled. Here are the symptoms that we're looking for relief from for you. And here are the occupants of those niches. How good a job is each one doing? And does the medicine get job security and an extension of its contract? Or do we say it's not so clear what particular drug is doing for you? So before I ask about adherence, I got to know, do you believe that it's really helpful? Here's a tip. Something that we call measurement-based care is sometimes a very useful way to quantify what I just said. So that means using rating scales. And some clinicians do this often and some not at all, and some in between. So if I'm treating you for depression or anxiety or insomnia or agitation or substance cravings or insomnia, or you pick, we can quantify the symptoms. There are rating scales that are out there that will actually give us a number that's been validated, and we can say, so before you started drug X or drug Y or drug Z, your symptom score was here. Now we impose whatever the treatment is, and an appropriate amount of time goes by, 4 to 6 weeks, whatever that may be, and let's re-rate things. If your symptom rating scale, like a thermometer, has not come down in a meaningful way, we cross this drug off the list. Your symptom level was here on day 1, and it's still here on day 42. There is no point in continuing this medicine. It just gets added to the heap of things you're taking and drives side effects and shaky adherence, as well as rightful ambivalence on your part. Why am I going to keep going back to the same thing that's not helpful? Whereas if I am using a rating scale to track symptoms, or for that matter, side effects, or for that matter, satisfaction or quality of life, or otherwise just some measurement by which to unequivocally, you and me together can say, is this helping you? A little, a lot, somewhere in between. That really allows us to then come back at whatever point in time and say, this treatment really deserves a place in the regimen, in the roster of what you're taking. It's earned its keep. It is doing what we want it to do. And if it ain't, there's no point in retaining it. But if it is, now we can move on to other side effects. Are there drug interactions? How complicated is it to take? And could it replace anything else? Certain medicines may work so well that they might even offer the prospect of replacing something else. Some medicines have very short half-lives. That means how long till the drug reaches steady state or leaves your system and requires multiple dosings. Some medicines can have abrupt wear-off effects, which can feel unpleasant, or withdrawal effects. Oh, people talk about, say, SSRIs, serotonin reuptake inhibitors, that if you miss a day or two, you get electric jolt feelings and brain shocks and vertigo and dizziness and nausea. Who wants that? So we want to proactively ask about side effects. And if we can simplify your regimen, that counts for a lot. All right, well, so I've been touching on a number of features that I would say contribute to issues of adherence around drug attitudes, efficacy versus tolerability. Is a medicine that's in a regimen earning its keep and is truly making a beneficial contribution as opposed to an ambiguous one, as we collectively do a kind of a shared decision-making process of the pros and cons of things, factor into this cost, access to care. There's a lot of complexity, I think, that goes into all the things that we're describing. I want to amplify a comment I just made about this notion of shared decision-making. And again, this book that I just published talks a fair amount about this. Shared decision-making is really a brokerage proposition between two people. The one who wants something and the individual that thinks they can offer some help. Let's say this is the clinician and this is the patient. And it really involves a dialogue of helping the patient, the person seeking help, articulate what are they looking for? What are their goals? What do they want? What do they not want? And then the clinician using their hopefully expertise to broker a fit. The best example I can think of with this is, you ever watch those real estate things on like HG television where there's a realtor out there and they're going to go and meet with a prospective client to get a new house. And they say, all right, what are you looking for? What do you want? It's got to be 3 bedrooms, at least 3 bathrooms. It's got to have a fenced in backyard. It's got to be near transportation. Okay. And then you want to identify the must-haves and the want-haves and the deal breakers. And what's your past experience been like? Where were you living before? And what did you not like about where you were living before? Because there may be things about your prior experience that will influence your satisfaction with whatever I can offer you next. Anyway, shared decision-making more than anything else is fostering that kind of a dialogue, which ideally the clinician will be able to say at the end of the dialogue, so let me make sure I understand what you're looking for. You've experienced this illness for many years. Predominantly, it's involved depressions. It's involved periods of suicidal thinking. It disrupts your concentration. It makes it hard to work. It makes it hard to maintain your family. It can lapse into periods of anxiety. Maybe there's been some substance use in the picture as well. Prior things you've tried have had the following troubling disincentives to adhere to the regimen. You didn't like significant weight gain. Who would? You don't like sexual side effects. You felt kind of dulled cognitively with this. So let me make sure I know what you're looking for. And now let me show you whatever real estate is available in this neck of the woods that meets the criteria that you're looking for. And we may not get it perfect, and there may be a trade-off. It may be, for instance, you want 4 bedrooms, but it's got to be within such and such distance of the train station. I can't do both. So which matters more to you? You want an anti-suicide effect from medicine with no weight gain, but also no sexual side effects. That may be a tough one to do. I can think of things that will do one, but not the other. Anyway, a good dialogue, I think, between provider and patient, makes very explicit what these goals are. And this, I would argue, is one of the useful ways to try to minimize poor adherence, to the extent that poor adherence represents miscommunication. Uh, the realtor sold me this house, but didn't tell me that there was an underground oil tank, or that it needed radon mitigation, or that the backyard that had overflow water issues. So I'm not going to be happy with what I get if I don't feel that I've been presented with a very well articulated summary of what I'm in store for. So I offer the proposition that as you're collaborating with the people that provide treatment to you, you come armed with questions, and backup questions and contingencies. So if this doesn't work out, then what? What's the next step in the process? If I try this out, is there going back, or are there implications? So this gets into adherence too, right? If I'm going to embark on this treatment but I don't like it, what's the backup plan? I think this is actually very important, because one thing I will say to patients, or try to remember to say to patients, is that not staying with the treatment regimen is a common enough thing. I have one request, which is, if you're not happy with the 3-bedroom, 4-bathroom residence, rather than bolt or just disappear, loop me in and tell me, Dr. Goldberg, I'm not happy with the following things. To which I will hopefully say, I am so glad you told me that, because now maybe I can do something to help with this. So a big problem with adherence or non-adherence is people sometimes take matters into their own hands. They will just stop a medicine, not tell anybody, or think as if they were to tell their provider that they don't really like what they're taking, they're going to get, I don't know, berated or otherwise get into a debate or a struggle, rather than a dialogue, which is, thank you so much for telling me what's not to your liking about this. Let's go through the pros and cons and the alternatives. And then my job is to make sure you understand all the options that you have available to you that I think are viable and reasonable. And then we together will decide, all right, I'll put up with this potential side effect, but not that side effect. Or I'm very open to taking an antidote medicine. Weight gain is a big disincentive for a lot of people to take medicines, and not all, but some or many psychiatric medicines can cause weight gain. For years, we often would just avoid medicines as best we could, or put our head in the sand. We now have a fairly large, growing list of treatment options that can be antidotes for psychiatric-induced weight gain. So that's a dialogue to have. And I would hate for someone to think, well, I'm not going to take this medicine because of concerns of weight gain. And here, too, when it comes to adherence, the prescriber can really offer useful information. For instance, let's take the medicine clozapine. That's generally used in schizophrenia, but it's also been studied in bipolar disorder and has been shown to work when other things don't, particularly in hard-to-treat mania. And if you didn't know this, it's the only drug that the FDA says can reduce the chance of suicide. The only drug, not lithium, not ketamine. Lithium is the one and only that's been, clozapine is the only one that's got an official statement in its label, but it's got a lot of side effects, including weight gain. So, and I'd rather not take that medicine. Thank you. I'd rather risk a 4th suicide attempt. I'd rather not have a dialogue about the pros and cons. I bring this up as one example of the epitome of shared decision-making. Someone who's a potentially excellent candidate for that medicine, but there are side effects, might assume it's my way or the highway, and I just am not going to do this, rather than, is there a way to make this medicine more acceptable? Are there ways to counteract or override side effects? And last but not least on this point, how unique is this medicine? So clozapine, again, as an example, doesn't really have an alternative. It's like its own thing. We have a few things like that in psychiatry that are their own thing. Lithium, kind of its own thing. ECT, electroconvulsive therapy, it's kind of its own thing. We don't have a, here's the next best thing to it. Maybe we have the next best thing to it, but there's not interchangeability. So we'll often say to patients, here are the viable options for you. Here's what's been shown to work. Here's what's evidence-based. Here are the pros and cons. And if it doesn't work, we can think of other things, but this is sort of the top tier thing. So we don't want to dismiss it or um, act as if there's plenty of other things behind it if there aren't. Sometimes there are. Sometimes this illness is easier to treat than others. But in people that have been through many medicines, adherence issues become especially difficult or challenging if we don't have a lot of other options. So again, back to the role of the clinician, not to tell somebody, you know, you got to do this, but rather, how can we make it more acceptable? Because if we have a finite number of treatment options, what do we do? A few more things I want to say, but then we'll pause for some discussion and questions. Some of you, or many of you, hopefully, are aware that the mode of delivery of certain medicines can also play a role when it comes to adherence. So drug delivery formats include oral medicines, but also includes long-acting injectable or LAI formulations of certain medicines, in particular medicines that are called antipsychotics that are now more widely used than just to treat psychosis, medicines that can treat mania regardless of psychosis, such as aripiprazole or quetiapine or acenapine, drugs that can prevent relapses, maintenance treatments like olanzapine or quetiapine, drugs that can treat the depressed phase of the illness. Some drugs called antipsychotics are really antidepressants. Lorazepam, that's Latuda, cariprazine, that's Vraylar, lumateperone, that's Caplyta, are all FDA-approved antipsychotics that treat depression. So some medicines have a very long half-life, and that can be very useful when adherence issues come up. The drug Vraylar or cariprazine has a half-life or a duration that goes on for weeks and weeks. So here's a little secret nobody will tell you. If you're on that medicine, Caplyta, and you miss a dose or two, it doesn't matter as much because it's going to take weeks to leave your system. That doesn't mean carte blanche, blank check, feel free to be non-adherent. It just means that if adherence has been an issue, we might want to pick a drug with a long half-life, such as Caplyta, knowing that that's going to be a little more forgiving than a drug with a short half-life, where if you miss a dose, you're going to have more trouble. Long-acting injectables are not unique in psychiatry, actually. Birth control formulations come as long-acting injectables, Depo-Provera. Women who don't wish to get pregnant or are using birth control to regulate menstrual cycles sometimes get an injection where for months that will serve their purposes. And so it's not, there are other examples of injectable treatments that buprenorphine can be a long-acting injectable. Medicines like aripiprazole or risperidone or olanzapine are the examples of long-acting injectables that can have a very dramatic impact on sustaining wellness and on relapse prevention. It's listed in practice guidelines as a top-line treatment. And I just want to quickly show you a couple of studies, and then I promise I'll stop and we can have time for discussion. So just as an example, the long-acting injectable form of risperidone compared to placebo has a much lower relapse rate. This is almost a straight line once you're on a steady state level of the drug, whereas if you're on placebo, relapse. Particularly valuable to prevent highs. And the drug aripiprazole has a long-acting formulation. It's now available as either once a month. There's a newer emerging once every 2 months formulation. And the once monthly version has a much more sustained recovery rate. That is, you get on this medicine, and if it's keeping you well, you get a shot once a month. 80% chance you will stay well out to 1 year. That's a really good statistic. And it's a sort of safeguard against poor adherence. So I've known some patients who will say things like, it's my insurance policy. I don't have to worry if I forget the medicine because I know that it's in my system. So anyway, I'm going to stop with the slide sharing. I've tried to touch on a number of what I would consider to be practical, useful points about medicine attitudes, reasons for non-adherence, which I suggest is not simply non-adherence. It's almost an expression of, are you happy with your treatment? I mean, people are usually more non-adherent with things they're unhappy about than they're happy about. If I think about this, how many people I ever talk to who say, I'm thrilled to pieces with the medicine you give me, I just don't take it. I mean, there must be something you don't like about it. And I submit that non-adherence is your means of voting with your feet and expressing to me that you're not happy with it. So let's talk about what you're not happy about and see if we can remedy that. Anyway, let me stop here. I want to make sure we've got some time for questions or anything I left out you can ask me about. So I'll turn things back to you, Jake.
Thank you so much, Dr. Goldberg. Going into our question and answer session, our first question is there a way to approach someone who's refusing a diagnosis and has said that they would not consider medication even if there is a diagnosis?
Hmm. Well, I guess here I'll say the operative word is curiosity. In mental health, we like to understand why people think what they think. If someone outright says, I know there's cameras recording my movements and people are spying on me, it's never helpful to say, that's not true, or no, they're not, or otherwise oppose a strongly held position. Far more useful to express some sense of curiosity. Help me understand how you know this to be the case, and help me understand what your emotional reaction to it is. So, how would you feel if you were being spied on or recorded? Upset, invaded, furious. So, what all happened that led to your being told about a condition or a name for a condition or a diagnosis that you are saying this does not pertain to me? Or even if it did, I don't want to take medicine. So, I would be very encouraging of a dialogue around that and a sense of curiosity. What does it mean to you? Um, um, and you'll get a zillion responses. It could be, no, no, there's no way that that could apply to me. Well, if other people have thought so, how do you understand what other people think? What's your understanding of the perception of others? If it's stigma, I don't want that diagnosis, whether it's accurate or not. You're told you have cancer. Can't be cancer. I don't want cancer. It's got to be a benign growth. Well, nobody wants a cancer diagnosis, but how do you decide if the information you're getting is just objectionable or inaccurate? That's an important distinction. What is it you don't like? Is it the message? Is it the messenger? Is it some implication? What would it mean if that were the diagnosis? So I have a zillion curiosity-based questions about what goes into your reaction to the information you got. And sometimes diagnoses are not accurate. In psychiatry, we make clinical diagnoses. We don't really have lab tests to confirm things. And that's not unique to psychiatry. Headaches, migraine headaches, there's no tests for that. Tinnitus, ringing in your ears, there's no test for that. Irritable bowel syndrome, there's no test for that. It's a clinical diagnosis. So you want to explore and understand. And then what are the implications? And hopefully one is trying to form an alliance with someone. And if someone is resolute, I don't want to hear it, la, 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 la. It may be a marathon, not a sprint, and a long-term engagement proposition. There are times, last but not least, when someone is resolutely opposed to an intervention or a diagnosis, but they're not able to take care of themselves, or they're endangering their own welfare or that of others. And that is an instance in which society steps in and might impose treatment. Nobody likes that concept of imposed or involuntary treatment. You have a right to object to things as long as you're not endangering yourself. You have a right to smoke cigarettes or eat junk food or not exercise. Nobody forces you to do those things. But if you're having a heart attack right here and now, we impose treatment on you. So we'd like to avert terrible catastrophic outcomes. We'd like to instead engage people and not have it fall into a position of catastrophe where involuntary treatment happens, but sometimes that's the case.
Mm-hmm. Very well said. So our next question is, if someone responds to a treatment or medicine very well, is there any chance that further down the line they'll experience side effects or it becomes ineffective?
Oh, excellent question. Thank you for that. So, separate things. Some side effects make themselves known sooner than later. For many, that's the case. And oftentimes that's adjusting or acclimating to a medicine. Nausea, headache, insomnia, irritability, drowsiness. And you ask your prescriber, what are the most common side effects that I might expect to see? And are those early on or later on? When do they occur? And are they transient? Do they pass? Are they dose related? Like if the dose goes up, is it going to happen more? Or is it more of an all or none thing? And what's the duration? Weight gain, for instance, with some atypical antipsychotics, isn't so transient. It can go on for a year before it starts to plateau. So it's worth asking which side effects tend to be early on and transient or early on and persistent. It's rare to get a new side effect, to the person's question. It's rare to get a new side effect well into the experience of the medicine, with just a few exceptions, just a few. Tardive dyskinesia, tardive, slow onset dyskinesia, uncoordinated motor movements, which has a risk of about 2 to 3% per year in people who take atypical antipsychotics. And some people have a higher risk than others, older people, women more than men, people with a mood disorder. Some studies say smokers are at a higher risk, or diabetics are at a higher risk, or the dose of the medicine may play a role. But by definition, that's a condition that occurs later on over the course of time. I'm trying to think about other late onset side effects besides that kind of movement disorder. If someone's having weight gain or changes in their blood sugar, they could potentially develop diabetes over time, but that's not a late onset thing. That's a progressive kind of thing. And that's an example where you'd want to identify a side effect early and intervene early. The drug doesn't know the difference between a benefit and a side effect. You could equally ask, if the drug isn't working, would it kick in after a year or two? Rarely. So we usually, for the most part, attribute cause and effect to a window of 1 to 3 months of exposure, because after about 3 months, you're suddenly getting better. Did the drug kick in? Maybe, but not necessarily. Or did the drug suddenly have a new side effect? And lastly, if a late suspected side effect comes along, you got to look for other explanations. So certainly possible you might get a late onset side effect. If a drug has a long half-life, like Vraylar does, it's possible that it would take some number of weeks before a side effect might occur, because it takes weeks to get to a steady state. But for the most part, if you've been on a medicine for a long time and you get a rash years later or something, you want to make sure you're exploring other more likely explanations before saying, this thing I've been on for 5 years all of a sudden gave me indigestion.
It's a great answer. So our next question is, are long-acting injectables ever the first or second line of treatment?
It sure can be. They should at least be brought up, I think, in terms of a sense of autonomy and patients being able to make informed decisions about their healthcare. So we usually think of these long-acting injectables as a strategy to manage adherence. Now, if it's a first line, first episode patient, they may wish to have some experience with oral medications and see how that works for them. They also may want to take as their mainstay drug, not an antipsychotic, but a drug like lithium or Depakote or lamotrigine, or something that's in the mood stabilizer category, and see how they fare. So there's no reason the long actings can't be first line, but I think they're more often second line and probably shouldn't be 10th line. What do I mean by that? All right, you've had an episode, you go out into the world, and then if adherence proves to be a problem or relapse occurs, that's the time to have the dialogue. When I supervise residents who work in the hospital, and a patient comes in the hospital because they stopped a medicine and they've relapsed, and the resident brings up, well, how about a long-acting injectable? And the person says, no, thank you. I will tell them, it's good you brought this up, but this is a long-term proposition. So you might say, okay, now may not be the time to have this discussion, but I want to at least plant the seed in your mind. Because if I see you again 6 months from now, I'm going to bring this up and say, you were just in the hospital in April and now you're back in September. Maybe we should be thinking about this, because if one of your goals is to not get rehospitalized, I'd be remiss to not bring this up as an option that can be very helpful sooner than later.
So our next question is, Are there any non-offensive ways that family members or friends can ask their loved one if they're taking their medication?
Yeah, I think very transparently and plainly. I think the non-offensive part is not the question; it's how it's asked. So, what's the difference between saying, I'm concerned about your welfare, um, and I feel like I'm part of your treatment team. You've asked me to be part of your treatment team, so I want to check in with you about your medicines. Are you finding they're easy to take? Are you finding it's hard to take? Are you talking with your doctor about it? I'm not here to check up on you. I'm here to be your cheerleader and your supporter. Um, I think you're having symptoms. So I would be remiss to not ask, are you missing doses? And if so, do you feel like you have to cover that up? Or do you feel like I'd be real judgy if that were the case? Real quick anecdote. I once had a dentist. I don't like to floss my teeth. Once had a dentist who said to me, do you floss your teeth? And usually I would say, oh, of course I do. But I like this dentist. I said to him, I got to be honest with you. No, I don't. And he said, yeah, flossing can be really difficult. Your teeth aren't that well aligned and it could be uncomfortable. I get that, Joe. Ever try flossing? Ever try water picking instead? Didn't know that was an option. Oh, yeah, I water pick. I hate flossing. Man, I love this guy. Uh, and I bought a water pick, and my gums are much healthier because of that. So he approached me about a topic that I could have just as easily blown him off with by empathizing with my plight and offering a sense of validation from my experience. He didn't say, "You're not flossing, are you? You want to lose all your teeth?" That would have gone over really big, right? No, he found a way to approach me. So I think how to approach the question is a very valid question. And you really would be remiss to turn a blind eye if your loved one is symptomatic. So I would approach it with empathy, with curiosity, with, are you talking with your doctor about this? And lastly, how can I be helpful to you in this? You can't. Well, I hope there'll be a time where I can, because I really care about your welfare. That's your overarching message. I care about your welfare.
Well, that's a great example. So we have time for one more final question, and that is there any alternatives to blood work?
Depends on the medicine. Um, Lithium specifically requires monitoring of your kidney function, usually every 6 months, your thyroid function, and lithium levels secondarily, because you don't want them to get too high, but mainly kidney and thyroid. Valproate, Depakote, um, mainly requires monitoring of liver tests and platelets in your blood cells because of a small chance that those things could become abnormal. Lamotrigine has no blood work associated with it. The drug Tegretol or carbamazepine could lower your white blood cell count and could affect your liver functioning. So that usually does need every 6 to 12 months blood work. All the atypical antipsychotics could raise your blood sugar or raise your cholesterol. And so the experts say, well, as part of good healthcare, you ought to be getting those things checked annually. And quite frankly, everybody should be getting those things checked annually. If you're taking an atypical antipsychotic, you've got a higher risk for high blood sugar or high cholesterol or high triglycerides. So you especially should be getting those things checked. So it depends on the drug, and all the other drugs that I didn't mention don't really have blood work associated with them. So it depends on the drug and depends on the person and what the risk factors are. If I'm obese and hyperglycemic, I'm getting my blood work no matter what medicines you give me. So it's part of good self-care.
Well, thank you for going in depth on that. And that wraps up today's webinar. I want to thank everyone in attendance. This will be available on ibpf.org and on our YouTube channel, International Bipolar Foundation. And Dr. Goldberg, thank you so much for this discussion. Our audience benefited so much. I benefited so much. And I want to ask you if you have any closing comments.
Oh, just I always like to impart a message of hope. And that's not just hyperbole. There are treatments we have now that we did not have 5 or 10 years ago. There are drugs in the pipeline. There are strategies to manage side effects like weight gain and tardive dyskinesia. So there's reason for optimism, honest to goodness optimism. And it's critical to think of the person you're working with for treatment as a collaborator in the process, never like an adversarial sense of what my healthcare provider wants me to do versus what I want to do. So you want to find the common ground and work together, as is the case with any healthcare relationship or dentist relationship, because everybody's on the same should be on the same page with the same goal, is to optimize your health and get you to recovery.
Mhm. Well, thank you so much. Have a great day, everybody.
Thank you all for joining.